Good afternoon, everyone, or morning, depending on where you're watching this from. It's my pleasure to welcome you to the 2025 Philip R. Nader Legacy of Health Lectureship. My name is Deanna Helsher, and I am the Regional Dean of the University of Texas Health Science Center at Houston School of Public Health in Austin. And I'm also the founding director of the Michael and Susan Dell Center for Healthy Living. We have a vision of healthy children in a healthy world, and you can't have a healthy children in a healthy world without healthy parents and healthy communities. So we advance health and healthy living for children and families through the research that we do, through innovative community-based programs, and then dissemination of evidence-based practices. As the center, we provide many resources for you to use. Please use your phone and look at our QR code to visit our website. But we have resources that include webinars like the ones today. We have newsletters, we have expert blogs, social media. We have a lot of research and resource stations that you can look at. Our Texas Health Status Reports, which show the status of children's health in Texas from 2021-23. Those are brand new. And then policy resources through our Texas Research to Policy Collaboration Project. So we are pleased today to partner with the Cizik School of Nursing at UT Health Houston to offer nursing contact hours for continuing education. So this has been approved for 1.5 contact hours of nursing professional development for the lectureship today. So attendance and completion of an online evaluation is required for you to receive credit for this. But we'd like to thank the Cizik School of Nursing for helping us get this approved for the contact hours. In addition to nursing CEUs, we are pleased to offer CHES, MCHES credit, and then RD/RDN CPEUs. So for this webinar. So we do have information about providing credit later on. So you'll see it here, and then we'll also follow up with it later. For nursing CEUs, please scan the QR code to complete the required evaluation at the end of the presentation. If you indicated that you'd like to receive CHES, MCHES, or the RD/RDN credits, when registering, you will receive further information. So look for that in your email after the conclusion of today's webinar. The learning objectives for today's presentation include being able to describe the principles of culinary medicine and the food as medicine model in the context of primary prevention and community pediatrics, to explain how food as medicine strategies can be integrated into patient care and health promotion, to apply building culinary medicine as a catalyst framework to enhance clinical practice, community health initiatives, and patient education. We're very excited to have Dr. Albin with us today. She has a recently published paper that describes some of her methods, and we're just so excited to hear it from her during this webinar. So neither the planning committee members nor the presenters today have disclosed any relevant financial relationships related to the planning or implementation of this CNE activity. We have no conflicts of interest to disclose to you. And so you can see the rest of the announcement there. So I would now like to talk a little bit about the Srila Vibhu Sharma Endowment for Excellence in Community Nutrition, Climate Health, and Sustainability. The Center for Healthy Living houses several endowments, such as this one, that provides for this lectureship. So the Srila and Vibhu Sharma Endowed Fellowship was established in 2018 to provide a stipend and project experiences for selected students. So they primarily work with Brighter Bites, a nonprofit organization that was co-founded by Dr. Srila Sharma, which aims to improve eating behavior of children and families by providing routine distribution of produce along with nutrition education programs in schools and in homes and also in other community settings at this point in time. So as part of the fellowship, the students receive a research commitment of 2 semesters, and they're able to participate in this project. And it's really been a fantastic professional development opportunity for them because they've been able to write manuscripts, conduct data analysis, really work with the public health research, and then they've been able to be co-authors on publications and presentations. So it's really been productive and a great learning experience for the students. So since 2017, we've had 11 Sharma Fellows who've gone on to use their experience to better public health nutrition. And you can see a pictures of them here. So I'm also proud to announce that this is the first year that we are welcoming a new addition to the Sharma Fellowships. And so what we have done, what the Sharmas have done, is add additional fellows in climate health and sustainability. So please join me in welcoming the 3 new fellows this academic year who will support community nutrition, climate health, and sustainability. So they are Catherine Joseph and Tyson Murray for the Excellence in Climate, Health, and Sustainability Fellows, and then Shiyang Yang as the Excellence in Community Nutrition, Health, and Wellness Fellow. So we really kind of acknowledge what the Sharmas have done. This is really a boon to public health in general, and especially to the fields of community nutrition, health and wellness, and climate health and sustainability. So we are so proud of these fellows, and additionally so thankful and appreciative to the Sharma family for their commitment to public health. And with that, I will hand it over to Dr. Sharma to describe the Nader Fellowship.
Thank you so much, Dr. Hulsher. And good afternoon, everyone. I'm Srila Sharma. I'm a professor of epidemiology and director of Center for Health Equity, as well as faculty member at the Michael and Susan Dell Center for Healthy Living. And today we are very fortunate to host our 10th annual Philip R. Nader Legacy of Health Lectureship. Before we jump into the lectureship itself, we would like to thank the Nader Endowment for funding this event. I would also like to talk for a minute about Dr. Nader's legacy, since he is the reason we are hosting this annual lectureship. It has been said about his career as a teacher and community researcher that the impact of Dr. Nader's work was more often felt than heard about. And both Dr. Hulsher and I have had personal interactions with Dr. Nader and have experienced his generosity and mentorship as well. The Nader Legacy of Health Lectureship is designed to educate and inform academics, providers, public health students, and community members about early life cycle systems. This event is intended to stimulate cooperation and collaboration among physicians, patients, families, and communities. The goal is to move forward towards improved health status for both parents and children. A legacy of health for generations to come. We are so thankful for Dr. Nader's vision and leadership in this space. And also just share a little tidbit that I learned about him, which is that ice cream was his favorite food. Next slide. We also want to share the past speakers we've had as part of this lectureship. And here's a historical view of all our keynote speakers, supported by Dr. Nader and his vision for the lectureship over the past 10 years since 2016. Well, now it's my pleasure to introduce this year's keynote speaker, Dr. Jaclyn Albin. Dr. Albin is an associate professor of internal medicine, pediatrics, and public health at University of Texas Southwestern. She is the inaugural director of UT Southwestern's Culinary Medicine program, which teaches nutrition and care innovation through hands-on cooking to students, healthcare professionals, and the community. She developed the first culinary medicine clinical service line, integrating interprofessional culinary medicine consults and group medical visits into patient care. Dr. Albin also serves as medical director for Food as Medicine Innovation at the Center for Innovation and Value at Bartland Health. She's an advisory board member for the American College of Culinary Medicine and the Teaching Kitchen Collaborative, and she studies the impact of culinary medicine and food as medicine in medical education and health system strategy. She strives to blend innovation, research, and community partnership to creatively build strategies that promote sustainable nutrition security and human thriving. Well, with that, I will hand it over to Dr. Albin for her keynote presentation on culinary medicine as a catalyst, bridging public health, primary care, and community partnership. Dr. Albin.
Thank you, Dr. Sharma. Good afternoon, everyone. I'm so honored to be here and to follow in the footsteps of Dr. Nader's legacy, and also to follow my good friend, Dr. Kofi Essel, who was the speaker last year. And I titled this talk of culinary medicine as a catalyst because I was thinking about the term catalyst after helping one of my kids with their science homework and how it accelerates a reaction and it can help move forward things that are stuck. And that is so perfectly descriptive of where we are today in public health. There's a lot of things that we need to catalyze in the right direction. And I believe culinary medicine, and specifically sharing the power of food with others, is part of what's going to drive us forward in that space. So on the next slide, I want to just start by saying this is about food. And I love taking pictures of food, and I take pictures of food that I prepare, that other people have prepared. These are just a few from the last couple of years where when I look at them, they mean something to me. I think about where I was, who I was eating with, what the experience of the food was. And I think that food does that for each of us. It's a connector, it's a celebration. And even this morning, I was with a group and asked them to tell me a little bit about what food means. And I had students do the same for me recently and created a word cloud to show you, because the answers are pretty consistent no matter who we talk to. And yes, food is for fuel and nutrition, but it's also for so many other things. And if we want to use food-based strategies as a catalyst for public health, we have to understand the nuance and the complexity that varies from individual to individual and community to community. That's part of the beauty, but also part of the complexity in this work. And before we dive into talking more about culinary medicine and food, I also want to say that it's about more than food. And on the next slide, I just want to highlight 3 core domains that I think are key to understanding how we contextualize this. No one can deny our healthcare system's access problems and cost are skyrocketing. This is true everywhere and across every demographic of patients. So that's one domain where this has to intersect and fit. Also, we're in a time of scientific advancement that's really exciting, where we're understanding increasingly how the food that we eat, what you had for breakfast, can literally impact the way that your DNA is read and transcribed, and how that epigenetic expression of our food environment affects our health in huge ways that we're just beginning to understand. And so food is complex. in its impact on our DNA, in its impact on our health, but also beautiful in its impact on our connection and our community context. It brings us together. And in fact, sharing a meal with people who think and look different than you is a wonderful way to build bridges. Because what we need to do in the times that we're facing right now is build bridges to one another and understand where we're coming from. But that doesn't mean we neglect that there's also a huge policy context to this work. And I hope you can see everything I share today as making the most of the circumstances that we have while still working long-term towards seeing the policy shifts that we need to see. So on the next slide, I want to briefly introduce culinary medicine. I hope most of you have heard of this. But fundamentally, culinary medicine is a multidimensional field that's about bringing together evidence-based nutrition science, what it is that we should eat for health, both at a public health lens, but also sometimes that's very individual, and then pairing that with culinary tradition and literacy, because it doesn't even matter that something's nutrition if we don't eat it. And we have to enjoy it and find it accessible and appealing to the other people that we feed if we're going to be able to eat it with regularity. And then the third piece of this is connecting it back to health. It's saying that nutrition science married to culinary tradition, married to health, have to come together to solve problems, bringing interprofessionals into this space who might not have collaborated before, but who have a real ability to solve problems together. So on the next slide, I'm just going to show you what I think the core problem here is and how culinary medicine can be a catalyst. We know a lot about what we should eat. Now, there's still confusion. If you go to TikTok for 5 minutes, you will find the confusion around what it is to eat. But actually, the science is pretty clear. We know what we should generally be eating. It's the how where people get lost, how they can access the food that they want to eat, that their family wants to eat. How do they fit it into a busy life? How do they prepare food? Culinary literacy as a skill, knowing what to do to make dinner tonight, is a skill that many have lost in our modern day convenience-based societies where it's just easier to pick something up. But unfortunately, if we want to drive health forward and respect our food system, we've got to get back to some of the roots of preparing more food in our home kitchens and with our communities. So I believe culinary medicine is the catalyst here by equipping people with the how. It equips clinicians, health professionals, to have meaningful conversations, not about nutrients, but about food. It equips patients and communities to drive forward their own health goals. And it makes this very practical. It says, here's food and here's the strategy to actually make the healthier choices easier. Because as humans, our behavior is driven by what's practical, realistic, what's easy. And there needs to be a lot of shift in our policies to make healthy choices easier, but we can give people strategy right now to do that. And then sometimes our medical interventions and our nutrition interventions seem cloud in the sky. They seem esoteric to our patients. So getting really practical, applying this to someone's everyday life, that is what this is about. And then finally, I believe the culinary medicine model is scalable, and it's a true pathway for us to innovate the things that are broken in our healthcare system. And we'll come back to that. So my next slide is just a roadmap. And I have been to a lot of talks and I have given a lot of talks where people talk about what they did and they share their research, they share their programs, and I'm going to do some of that. But I'm also going to do this in a contextualized way that hopefully helps every one of you here see, how do I take a piece of this back and fit it into where I am? So I'm giving you a roadmap here. We're going to talk about how building programs is about recognizing that something is missing. We're going to talk about how you have to do some homework for this to be successful, and you have to find your friends. We're going to invest in the next generation. We're going to recognize that this doesn't change with a single program. It changes with changing how our learners think about the way they deliver care, how they partner with the community, how community leaders innovate. So community partnership is centered throughout all of this, but we'll spend a little time specifically focusing on it. And we're going to talk about data, because if we don't study it and show that the outcomes are what we think they are what we want them to be, then we can't really make the case that we need to do it. We're going to talk about stakeholders and using our voices. Advocacy just means using our voices in the spaces and places where we have an opportunity to do so. And then I'm going to end the time by sharing a little bit about clinical innovation, how we've built culinary medicine into clinical care, because I think that's a way for it to get taken seriously and to drive forward its potential impact. And then my homework right now is, how do we scale and grow a program that's successful? And that's a question that all of us face at different times. So I'm going to take you through each of these 8 steps with a little bit of my own story and hopefully some inspiration for you to build yours. So on the next slide, we're going to start with something that I believe very deeply, and that is that our personal experiences often drive our most impactful professional work. My personal story with food began because I am the granddaughter of farmers. And I'm sitting on the tractor. I'm the little girl in the red hat, and my little sister is in my grandfather's lap on his farm in Lockett, Texas, which is one of the many small towns in Texas you have probably never heard of. But he was part of his, the entire generation before him, they were also farmers in Lockett. And then he ultimately moved to an even smaller town called Chillicothe, where he was an experiment station farmer for the USDA and studied different agricultural technologies. He taught me how to grow okra in my backyard that I still do today. And he taught me about the beauty and value of knowing where our food comes from and how to take it directly to the table. He also died of malignancy, of a blood cancer that his doctors tied to his pesticide exposure. And I think it's critical as we talk about food to think about farm workers and what they've invested in, the risks that they face, and how we need to consider that in the ways that we evolve our food system. So now I'm going to fast forward you about 30 years, where this is my family today, and it's my husband and adolescent children you see here, and both of my boys have celiac disease. And it was my husband's diagnosis of celiac disease, actually while I was pregnant with my son, that made me recognize the disconnect in what I knew about food, which was personal, and what I knew about medicine and health, which was professional. I was a resident at the time that he got diagnosed, and he came home from his doctor's appointment with his celiac disease or gluten allergy diagnosis and said, "I don't really know what we should eat for dinner. I hope you do." And that was a moment that catalyzed for me the need to build a bridge between food and health that didn't exist. So it started really small for us. We made our own food, and we took our food everywhere. We figured out how to avoid gluten at home, and I carried my lunch to work most days. And so actually what connected my professional and personal passions was very early in my career as a faculty member. Over 10 years ago, someone noticed that I always brought my own food and asked questions about it. And that led to me building nutrition education programs because I was clearly passionate about food. So I ask you what your story is that might drive what your impact should be. Because when you marry the two, your professional and personal passions, you will accomplish a lot. So on the next slide, I want to talk about why we decide we need to build something new. It's personal and professional, but it's also about just observing what's before us and recognizing that something is missing. So there's several domains where you might notice something is missing. You'll see maybe that something just doesn't work. Something's broken, something's inefficient. Maybe you see a gap and you say, there needs to be something that addresses this issue. And another big one that many of us face but often struggle to address is an imbalance between what resources we actually have and what the demand for those resources are. And sometimes we have excess in resources for something that's not actually doing very much. And it's really difficult to do the spring cleaning, as I call it, and figure out where we need to redirect our energy. You have to start with your why, because you're going to come back to it over and over again. So for me, the why was a recognition that the next generation of doctors needed to know more than I did about how to connect food and health. And that was the beginning of building culinary medicine. So on the next slide, we're going to talk about homework. Who thinks fond memories of homework? I spend a lot of time helping do homework these days. And there's a lot of tears that come with homework Because homework is really about saying what is already out there. If I've identified a problem or a gap, so I want to teach nutrition, so I want to bring a program to my community organization, where do I even begin? So you have to start by investigating what exists. And I actually think artificial intelligence is a good tool. You can put your zip code and say what programs exist in this zip code area that are related to put in your interest there. And you'll find community-based organizations. You might find health systems. You might find people. And you've got to find both programs and people. And then you have to take the next step to reach out to them and talk to them. They might be internal. In big health systems, we often don't even know what the other people in different departments are doing. And it could be very synergistic with what we're doing, but we have to find them first and talk about it. An example here is my partner in all the things culinary medicine at UT Southwestern is Millette Seiler, who's a culinary dietitian. And we were both delivering nutrition interventions. I was at the medical school, she was at our nonprofit cancer institute, and we didn't even know each other. And it took a conference presentation where someone who knew both of us introduced us that was external. And sometimes it's the weird ways that we make connections and realize, wow, we care about the same things. How can we advance this together? And then lastly, if you think about building anything new, don't start without asking more questions about what is actually needed and wanted. It's easy, especially as we develop expertise in a topic, to make assumptions that we know what people need. And then sometimes they tell us what they need and we don't believe them. So we have to be really, really strict with ourselves about asking and believing before we move forward. Otherwise, we might build a program and wonder why people don't engage with it. So the next slide, a little bit more about homework. When you are building something new, it often feels like this picture of my daughter who begrudgingly agreed to carry her brother's backpack along with her own one day because he was loaded down with some instruments. And when you start something new, it feels like this. And you wonder where everyone else is, why don't you have enough resources, and how long can you keep carrying an extra load? It also sometimes looks like doing things that don't feel like your job. And I think that we have to swallow that and acknowledge that there is a place to set boundaries, but that building new things requires adaptability, flexibility, and hustle. So you have to continually revisit that throughout the process. How do I build something new that's meaningful? And it's going to feel uncomfortable. And I have to think thoughtfully about where I draw the lines. When you build a new program, you have to also build trust. Not just with the people you're serving, but with the people you do it with, the people that are leading your organizations. And I snapped this screenshot of the clouds while I was sitting at a stoplight. Don't worry, I was not actively driving. And I was struck by the layering where there's darkness at the top and the sunset was trying to shine through the complexity of the cloud structures. And this is how building trust feels sometimes, where there's layers, there's light, there's darkness, there's confusion, but there's also beauty. And so recognize that's a very iterative process. And you will know you have built trust when people give you feedback that's uncomfortable. So remember, the theme here is discomfort is normal. And then lastly, I took this picture over the summer on a mountain road in New Mexico, and we were on the way to visit some friends. And there is a bull in that picture, by the way, if you can't tell, and his whole family, presumably. And they were just in the middle of the road. And we were scheduled to arrive at our friend's house. We did not get there on time because we spent about 30 minutes waiting for these cows to move out of the way on the mountain road. And everyone in my car had a different idea of how we should navigate this barrier. My 14-year-old son is like, just plow through them, Mom. And then my daughter actually started to cry and she's like, no, the bull will charge the car. And so everyone spent all this time arguing about how to get past this barrier rather than just sitting with it. Because sometimes we just have to wait. We just have to see how the overcoming of the barrier in the way. Many of you may be looking at a financial barrier and it feels insurmountable. And sometimes we just sit with it and we might not solve it at the timeline that we had hoped. So we're going to move past the discomfort a little bit now. And we're going to talk about training the next generation, because the next generation is who powers this work. And I am so inspired by the many medical learners and other learners that I have had the privilege of training, because they are the legacy of this. So training the next generation in the role of food and nutrition through culinary medicine is going to transform health. And I don't know how to tell you about the hope that they bring to me, but we bring pediatricians, internists, even surgeons into a teaching kitchen. We bring dietetic students and interns, PAs, pharmacists, community members, and together they share their culture, they share their questions, their beliefs about food. And we build a system where team-based care and team-based conversations are normative by sharing a meal. This is relevant to everyone. Everybody eats, and we all should care about the food that we prepare and feed ourselves and our loved ones. And we should care about the conversations that we have about food. And ultimately, training the next generation was what directed our programs to the community, which I'll come to in a moment. But on my next slide, I want to speak to public health learners. Because in my early days, I didn't actually have access to public health learners, but now they're becoming an increasing part of our programs because they bring skills that medical and dietetic learners might not have, like understanding how do you evaluate and implement community programs strategically. How do you build community partners and figure out what resources are already out there? There's also a lot of public health expertise around policy and how to use our voices. I think we can all agree that right now, there's some brokenness in our public health messaging. That part of why we lack trust with the communities that we want to serve is on us to figure out how to change. And the youthful generation asking our community, not just the adults, but the youth, how we need to be talking to them has opened new doors for our programs. And we just finished asking our community advisory board that's made up of teenagers, what do you see as the thing standing in the way about learning about food, changing the food that you eat for your health? And they gave us such rich feedback. Our teenagers are so insightful, and I think we need to keep asking them. And our public health experts are really the right people to find every voice that we need to listen to as we move this movement forward. And our learners catalyze change. I just want to share a few quick stories. This is a picture of people that I deeply value. We've got 4 dietitians here and a couple of physicians who are passionate about culinary medicine. We took this at our most recent American College of Culinary Medicine conference, but I just want to highlight what they're doing. So Amy Moyer on the left there, she's in North Carolina, and she has actually integrated culinary medicine into an entire dietetics program, and they graduate ready to get certified, bringing culinary passion into the traditional nutrition training and inspiring the next generation of dietitians to be leaders in the culinary medicine movement. And then in North Texas, in our program, we're focused heavily on medical education and patient care innovation, but also Dr. Ann Van Bieber, who's standing behind me, she was one of the very first people to lead culinary medicine integration into dietetics programming, and she actually trained Millette, my dietitian partner. And so you see the legacy already passing itself forward. And then in West Virginia, this is one of my favorite cardiologists who says, hey, prevention is really missing. And if we don't start in medical school and train the entire curriculum or train the entire generation of doctors from the beginning of their curriculum to the end of their 4 years in medical school, we miss an opportunity for them to see this as possible as a career path. So our learners are the force multipliers. They power the movement, and they also often tell us where to go next. And for us, Millette and I, we were told by our learners that we needed to get our programs out of the teaching kitchen on campus and into the community because they wanted to take what they learned to the people right away. And so that takes us to the next step in the journey, which is really building this in the community. I hope that most of you already know this. You already get this, that partnership with the community matters, but it's hard. And I think it's important to recognize that health systems and academics like myself don't always understand the community needs or limitations, and vice versa. Community organizations often have questions about why we prioritize certain things, and there can be a lot of beautiful work done to build those bridges where we elevate the work that each other does. So some of the key things that come out of vital community partnership is that we actually identify the right goals, because the goals that we think need to be addressed are not necessarily the most pressing. They might be where we see a grant or where there's a health system priority, but we have to be really careful that the alignment exists at the beginning if we want our programs to succeed. And then it also ensures that we get the right voices at the table and that we build trust over time. So there's still a lot of work to be done here. And again, back to the discomfort, it's part of the process to feel a little uncomfortable, to put yourself in a situation that you might not normally be in as you learn what your community is asking for. So in the next slide, I want to say something that's refreshing. You don't have to start from scratch. You might already have colleagues who have built community partnership that allows you to jump right in and swim. And that was true for me. So about 15 years ago, Dr. Sandy Pruitt and Tammy Leonard, who are two of my public health collaborators, they had been part of building a network of community organizations, including Crossroads Community Services, which is the largest distributor of food for the North Texas Food Bank in the Dallas area. And they are a distributor of food, and they do a lot of innovative things, but they also supply dozens, I believe close to 70 different community distribution partners who are distributing food in different ways relevant to their communities. And we have built deep trust where we mutually share the things that are working, the needs that we see, and try to solve the problems that we both find to have synergy in our collaboration. So when you do this over time, on the next slide, I want to talk about how this grows. And I think that it starts with us both caring about the same problem. So you start with the problem. And food insecurity is clearly a central problem to what the charitable food system is facing. It has not always been central to what the health system is paying attention to, but fortunately that's shifting. And now we can come together, and I call the food insecurity rate in Texas as not the silver medal that we want, because we're second to Arkansas as the second highest rate of food insecurity. We actually have the largest number of food insecure people. And if you look at the graphs at the bottom, food insecurity is continuing to rise over the last several years, and very low food security is rising as well. And those are alarming numbers. And it's something that we can all say, are we going to continue to choose this? Or are we going to take every tool that we have out of the box and figure out how to move forward? It's not always clear how to move forward when you have a health system over here and a charitable food organization over there. And so actually the long partnership that we built with Crossroads opened the door for us to really explore co-location of resources as a strategy that could work for our community, where transportation and other barriers also stand in the way. So that actually has inspired growth. So on the next slide, I want to talk briefly about a project that was led almost entirely by medical learners. These were medical students that we had trained through our culinary medicine program. They were the ones who said, we want to get out to the community. And Crossroads had told us, we're struggling because we have a lot of healthy food options. One example last year was butternut squash, and people are not taking it. They run a client choice pantry. So people who come, they call them shoppers at their pantry. They come and they pick the foods they want. And the shoppers were telling them, we want healthy recipes. We want ideas for what to cook with the foods that we pick. But they were also leaving healthy foods on the tables in the bins because they were unfamiliar. So they said, could you guys do something about that? So we decided to take an approach of, everyone who goes to Costco enjoys the experience of walking around and finding a sample. And you're like, I don't even know that I want that food, but I'm going to try it because it's a free sample and it's sitting right there. And so we created a similar model where we consistently sent medical students to deliver samples, and they designed recipes that our dietitians and chef teams vetted. And there were super simple recipes where most of the ingredients were acquired at the food pantry, and they were based on current inventory problems that the pantry was facing, where they had too much of a particular ingredient. And then they would demo the recipes, and they would offer a survey that was optional for shoppers to complete in English or Spanish. And they rated the recipes, both the ones that they tasted and recipes that had similar ingredients that were not demoed. And we actually found that the demonstration itself improved the appeal of a recipe, even with unfamiliar ingredients, and it also improved people's reported intention to cook it. Another thing that came from listening to our community was, yes, we need food and we need nutrition knowledge. We need culinary literacy, And we need the stuff in the kitchen, because if you don't have a cookie sheet, it doesn't do any good to tell someone a recipe to roast vegetables. So understanding the kitchen item ownership became a huge part of this project as well, where we learned that actually less than half of our patients even owned a measuring spoon. So if we're going to give them a recipe that's essential for, we should also be finding ways to give them the kitchen equipment that builds their inventory at home. So this project led to many, many more, and we continue to collaborate with Crossroads, and we really have turned our eye towards what does growth look like. So I mentioned co-location before. This project was conducted in a community food market, but our patients who are food insecure that come into the clinic, they come into the clinic right here where the clinic exists. We have a lot of satellite clinics all over the Dallas area. In our South Dallas clinic, we were finding that food insecurity that patients faced today was an overwhelming problem, and we didn't have anything to do about it. So we were actually able to get a grant to study the impact of referring people directly to food. And I'm going to tell you more about that in a moment. But on the next slide, I first want to show you a picture of a beautiful space that emerged out of an authentic partnership with Crossroads. So we were able to support a study that led to outcomes, that led to philanthropy, and built this gorgeous teaching kitchen. And you see the CEO of Crossroads, my friend Bené Watkins Chambers here. This kitchen is surrounded by a community food market that functions as a nutrition pharmacy, as they're calling it. And we can directly refer our patients the same day they are seen in our Parkland or UT clinics in our Redbird area. They can go over and they can sign up for classes, they can get immediate support for food, and they don't have to leave the campus. And this satellite co-location space is a model that helps us bring all the services to the same area. The health system didn't have to become an expert in being a food pantry, and the food pantry doesn't have to solve diabetes, but we can do this together when we bring our resources to the table in alignment. So in the next slide, I'm going to move into talking briefly about the complexity of this and why we have to study it. Because as I've said over and over, the food itself isn't enough. There has to be food plus nutrition education, kitchen equipment plus culinary literacy, and then we have to figure out how do we actually change human behavior. It's a tricky thing. Anyone who's got a spouse or a partner, you might have ideas about things you want to change about that person, and it doesn't go how you thought. I've just celebrated my 18th anniversary, and I like to tell people the biggest secret to success is beginning to accept the beauty of the person that you've committed yourself to, and also accepting what you can't change, because we are each accountable for the things that we are going to change and evolve about our own health. And it is very hard, especially when people are struggling to access the right resources. So outcomes is how we get more resources, how we make the policy shifts, how we make the healthier choice easier. So now we're going to talk about that. In step 5, I call it the data step, but really it's pilots and traditional research. And if you're coming from a community organization, you might not be able to get the resources to do the traditional research that people like Dr. Sharma excel at, because it takes big teams and it takes funding. And the way that we do this well is by partnering yet again to connect and build a bridge. So how do we track health outcomes over time? Even just sharing data between our community organizations and our health systems. Some of us were talking about this problem earlier today. It's huge. And then what are the community impacts of our programs? We have to build repeated bridges in order to make sure we're gathering the answers to these questions. And then thinking about it from a pediatric lens, when we look at a child, the health effects of their life experiences, they begin early and they often don't manifest for years or even decades. So sometimes it's really challenging to say, I look at a child through the lens of what might happen to their future as a med-peds physician. And I look at adults through the lens of the child's story. And if we don't have a holistic lifespan view for the way that we gather, collect, and measure outcomes, we're missing pieces of the puzzle that are going to build the bridges here. So on the next slide, I want you to just reflect with me about the possibilities about what you could study. These are just some of the topics that we've been focused on. We've been studying medically tailored groceries, and I'll tell you a bit more about that in a minute. We've also studied fruit and vegetable RX in a charitable food system context paired with cooking education and looking at how that impacts kidney disease. We are deploying community health workers. Send me a heart if you love community health workers, because I love seeing all of the engagement. Community health workers have an incredible ability to extend, expand, connect, and build trust. You guys are here for the community health workers. I love it because as community health workers work with dietitians and social workers and physicians and public health experts, we're going to be able to extend this all over our communities in places and spaces that we weren't able to reach before. And I'm excited to see how we continually add them to the equation and figure out how to fund the vital work that they do. Pharmacists and pharmacy staff, they want to be part of this too. And we just studied having a very low touch resource. We provide nutrition information and access to nutrition resources through pharmacies. And it's been really well received because people need to see this everywhere they go and they need consistent messaging. And I'll come back to telling you about culinary medicine group medical visits at the end. So just to briefly tell you on the next slide about our American Heart Association funded work that I did with my collaborators, Drs. Hollis, Hansen, and Leonard, where we said, can the charitable food system be the hub for sustainable food as medicine prescribing? Can we use the charitable food system to prescribe the food and have health system resources infused into the community organizations to help promote access and change? And so we randomized patients referred from the health system who had metabolic health problems. We referred them to our pop-up model. I showed you the beautiful photos of what eventually was achieved as a result of this study, but our original pop-up model was a much smaller little pantry space in the mall, which is adjacent to our clinic. It's actually an old mall where our clinic and pantry exist. And so with group one, we asked the question, how much does, and if you'll just advance the slide, is it enough if we just give people nourishing food who have diabetes? If we give them the access, is that going to move the needle on dietary quality, on diabetes? And then in group two, we asked the question, what if we make the healthier choice default? Remember, it's a client choice pantry. What if we set up your grocery cart for you and we say, hey, we're going to give you great options. You can change them if you want to, but we're actually pairing it with recipes and making it easier. And then our third group had the addition of coaching from a community health worker in the setting of shopping, where patients could talk about their health goals and get some support in making the changes that they wanted to see and overcoming some of their barriers. So we'll be sharing the results of this study soon, but I just want to share with you as a vital example of how deep community partnership was the thrust of the entire project. We can't do public health nutrition from the silos of academia. So on my next slide, as you think about what you're going to do next, it's going to come down to funding for most of us. And this is a painful time. So I think you start by saying, what am I even trying to fund? Am I trying to fund a program? That's a little harder sometimes to get funding for. If you can pilot something or evaluate something, it opens new doors for what you can get grants for. Think about who you can partner with, who has the skills, who cares about what this work is about, and let those people guide you towards how to evaluate. So I think all of us have to also diversify. I like to joke, it's like your retirement. You don't want to put all of your eggs in the same basket here. And we want to think about how to sustain our programs with a lot of variety. And that's actually what led me to using clinical models and saying, could clinical revenue drive food as medicine forward in health systems? And I absolutely believe that it can. And we'll come to that in just a moment. So on the next slide, we have to use our voices. And we also have to look at the programs that already exist before we forge ahead with new programs. So I'm going to show you a few of the existing programs in just a moment. So you have to approach them with curiosity, even if your thoughts center around what's not working, which many of us do. We also have to think about who our stakeholders are. Our stakeholders are everyone who eats, everyone who needs and buys food, everyone who makes decisions about the policies that really control the food that people have access to. And then lastly, we have to share our insights. And I think the advocacy word sometimes scares us because we say, well, I don't know how to change policy, or I don't know how to move the needle on this problem. It's really just about sharing what you know and what you care about, tying your personal passions and stories into the communities that you're serving. So on the next slide, here's an example of some common programs that some of us have feelings about. We think about the National School Lunch Program, and we think about WIC. These are some of the largest safety net programs that are often considered early food as medicine programs, but they have complexity and their ties to USDA priorities and other challenges. But we can look at these with curiosity and understand what works about them and what doesn't work about them and why. And then on the next slide, another huge program that we want to dive deeper into understanding, especially as the funding structures are shifting for SNAP. So what does SNAP participants tell us? We know that just giving people access to SNAP doesn't solve everything, right? Why? It's because eating healthy is hard. That's one big aspect of this. People tell us that it's challenging even if they have the resources. And I think some of that comes back to the other pieces of the picture, the culinary literacy. Feeding children is hard. When you're in a family environment where there's a lot of stress, you are likely not focused on getting the nutrients in as the #1 priority for dinner that night. And so recognizing that, and then also recognizing that for families, eating healthy feels expensive. And there's definitely a lot of truth to that, but it's also an opportunity for us to teach skills to build people's strategy around making the most of their resources. On the next slide, there's some more insights that SNAP participants have told us about why healthy eating is hard. And many of these are addressed in culinary medicine. We teach people how to be efficient, which can help overcome time barriers. We teach people how to store food more effectively so that they don't have to go to the store as often. We teach adaptive skills around how to overcome, maybe you've had a traumatic injury or someone who's been through chemotherapy and everything tastes different, or they have neuropathy. We have to overcome those types of barriers for our patients and families. And then cooking skills is something that our patients tell us they want all the time, and they feel so empowered when they're able to walk away knowing how to prepare healthy, delicious food. So on the next slide, I just want to give you a couple of examples of how you bring this together, thinking about where you live on the intersection. Are you in the food space, acquiring food, distributing food? Are you in the nutrition education space as a community educator, as a dietitian? Are you a chef or a dietitian who cares about the culinary arts? Are you somebody who cares about changing behavior? Maybe you're a CHW or a coach. Everybody on this spectrum, their skills are deeply essential to how we do this. And if we don't include each aspect, we will not be successful. So on my next slide, I want to just share a couple of ways that I've tried to use my voice. And when you use your voice, you have to be strategic. So I want to remind you that there are a lot of things to speak up about, and you don't have to speak up about all of them. You have to choose the torch that you're going to carry and carry it well. So one of the things that has bothered me throughout the evolution of the food as medicine movement is that we run the risk of making this too transactional, too much like medicine, the same kind of medicine I might prescribe for your high blood pressure. It's not the same. And so I like to continually infuse that it's about food plus people. And I think the kitchen gives that to us, because when we take people to the kitchen, that's where things become very human and where we build the skills for people to have autonomy and self-efficacy in their own food journey. And then another area that I've been passionate about is the Farm Bill. Doctors know nothing about the Farm Bill, but if they don't, they have no idea how the policies that are embedded into this affect their patients' ability to do anything that's recommended to them. And policy change is going to be a long game, but we have to continually speak up. And maybe you're not an academic and you're not going to speak up in publication form, which is my chosen venue, but it's on social media. There's a huge void in social media of evidence-based strategy and expert-based opinion. You might be the person who needs to fill a piece of that. Next slide. I want to remind us that we cannot be discouraged in times in which policy makes things harder, and we also cannot lead with emotion. So when you think about how to amplify your impact to promote policy change, to lead to the structural change that we need to see, take a moment and sit back and say, I'm frustrated, I'm angry, I'm scared, I'm worried, I'm nervous, I'm excited. We could have all the emotions and we need to sit with it a bit. Pretend you're in the car with me looking at the bull and you're trying to figure out the best way forward on a mountain road. It takes some time to know what our next steps are, and it's okay to not be sure. And as we wait, sometimes the doors open that we didn't expect. And for me, that's really been about clinical innovation. So take us to the next slide. And I'm just going to close telling you a little bit about the work that we've done. Primary care is struggling. It is really a problem. This study is one where they just looked at over 30,000 different people responded to talk about what are the things that are in the way of successful primary care. And I think still people are proposing a lot of changes that are Band-Aids. The same is a problem in pediatrics. So on my next slide, I just want, maybe we take a moment for the pediatricians. Their job is getting harder. I'm a pediatrician and I'm not practicing traditional primary care anymore. I'm seeing patients in kitchens. But my pediatrician colleagues are really struggling to know how to be the best advocates for their families because they don't feel empowered and their families don't feel empowered. That's what leads to child health. It's empowering families. It's answering their questions. It's overcoming their fears and it's navigating them to the tools to be able to find their way. And it's a time in which we need new tools to be able to do this because the existing tools are not enough and they're failing us. So next slide. How do we do this? I want to say that you have to stop and pause and say what isn't working about the current models, whether it's in healthcare or in community settings, and stop beating our head against the brick wall, because sometimes that's what we do. We keep trying to force a pathway that isn't there instead of looking for an unexpected way around. And it's critical to point out that we're making this up as we go, and that we are not going to have a playbook when we're innovating. We're going to say, there are such big problems that I cannot abide it. I'm going to do something different to open the doors. So that's really what we did in building culinary medicine. And the next slide is just showing you that patients want this information. They have asked for nutrition advice. They feel so confused by what they hear from doctor to doctor and dietitian to dietitian. They want food integrated into their care, especially those that are food insecure. They want us to ask about it. And they're listing diet-related conditions at the top of their priority list. So what do? We bring that to them in clinical care. And so at UT Southwestern, we took the bold move of saying, what if this looked like a culinary medicine service line? So on the next slide, you'll see that this is just our webpage. You can Google culinary medicine at UT Southwestern and read a little bit more. But even getting a webpage was a journey of explaining how culinary medicine should be part of how we meet people's health needs. And so on the next slide, I just want to walk you briefly through what this looks like. This looks like starting small. You always have to start smaller than you wanted to. We launched what's called an e-consult, which is just a written clinician to clinician consult where another physician in our health system could say, hey, culinary medicine team, which is myself and a dietitian, what do I say to my patient who asked this question? And we write back a response that they then deliver to their patient. And then we moved into solving a different problem where we said there's a gap in access to dietitians. And in our health system, a lot of patients can't see dietitians, and a lot of dietitians actually don't feel comfortable talking about food. So what if we, or with about cooking specifically, so what if we brought culinary dietetics as a resource into patient care with physician partnership for billing? So we started billing interprofessional consults where patients see both a physician who says, this matters to your health more than you know, and we want to equip you to be successful. And then they are able to access a dietitian who can talk to them not about just nutrition, but also what to make for dinner tonight in a very strategic and practical way, prescribing recipes. And then the third piece of this is actually delivering care in a kitchen. And these kitchens are not on our health system campus, they're in the community. And so on our next slide, you'll see, what does that look like? That looks like taking those community partnerships that we built over time. This is in Oak Cliff Bible Fellowship's kitchen that we were unpacking boxes together. You've got pastors, dietitians, physicians, and medical students in this picture, putting together tables and kitchen equipment for us to build out a model where we could deliver group-based culinary medicine care. And I'm just going to show you a few words that our patients have shared about this as we get to the end of our time. One of the things that made me most excited was when a patient said, a lot of people think this is hard. It's not, it's simple. We hope to bring that simplicity to our patients by taking them to a familiar place. We're literally in a church gym, sitting at tables, and then you see one of my medical students prepping stations in that same teaching kitchen. Patients find the simplicity of this life-changing. And then on the next slide, you'll see that it's teaching through experiential learning. And when someone is able to do this hands-on, they feel like they can do it again at home. They can replicate it. Another huge piece of culinary medicine is building relational community. People are very lonely, and this helps them feel less alone. They see that other people are struggling with the same thing. And then lastly, we've talked about behavior change. Showing people how to do something is much more powerful than telling them. So we're going to make tacos and we're going to replace half the meat with diced mushrooms and lentils. And guess what? It tastes the same and your family probably isn't even going to notice. And you got nutrients that you weren't getting before and you reduce the cost of the meal. That is an empowering tool to show someone how to teach their family to eat a little bit differently without radically changing what they're cooking, but just giving them small skills. So on the next slide, we're going to end with talking about how do we grow and sustain things. So my questions are, how do I take this to new places and spaces? How do we change other health systems to replicate this model? I'm really passionate about this. And I think the key is sharing our stories with our data. We talked about that all throughout, that you have to gather the data and then you also have to share how it impacts you. And then on the next slide, partnering with an organization in your community. If you don't have one, adopt one. And it really just means showing up and figuring out what they care about and what they're passionate about, what they need, and how you can work together. Next slide. Where can you go? I suggested AI earlier, and I'm not kidding, but even just looking around where you are, ask where you can show up. Because building trust with our community organizations and even building trust from the community to the health system involves being in the same places. We have to be proximal to the spaces that we want to build something new. And then on the next slide, I hope that you see with me that when we do this well, everyone can sail in the same direction. And we're not all in the same boat, and we don't have to be, but we're there and we're able to support and lift one another up if we run into trouble. So just the last couple of slides are just a few more ideas and reminders that if this feels hard, you're probably doing it right. And I say this over and over again because it takes a lot of tenacity to do hard things that go against the grain. Don't take no for an answer the first 10 or 15 times. Keep asking. Ask in a different way at a different time and involve different people, but maintain a willingness to do it differently, to pivot and to be adaptable. And then on the next slide, I just want you to think about your own self and how you keep your fire alive, because if we lose our fire, we are not able to be effective anymore. And we can feel discouraged. And sometimes we have to step back and just stay connected to where our feet are. Put your feet on the ground, go out to your own community and live the things that you want to see. And that can help reinvigorate you when you get tired. It's okay to be tired, and we can't always be thinking about long-term change. And then finally, understand the overlap of what you're doing in your health system so that you can be effective. You have to overlap your organization's priorities, capitalize on the strengths that already exist, and then find the people to do it with you along the way. If you are over here and your health system or organization is over here, you're not going to be effective. So find alignment is so key to success. And then if you'll advance to the next slide. So I think we've covered all of this, but to catalyze our communities, wherever we are, you have to know what the gaps are, find the people you want to do it with, Even if you don't like data, you have to get some or find friends who like to get data. Community has to be repeatedly recentered, and we have to think beyond the kitchen to the communities where people are cooking, eating, and growing together. And I thank you so much for being with us today. I hope that you feel inspired that you can take a step forward. And I want to remind you, in the words of Chef Jose Andres, we need to build bigger tables. There's a seat for everyone in this work, and we each have a very important role to play. And all of us have to keep showing up, and we'll find how we fit together to advance the progress that we want to see. So I'm going to turn it back over to Dr. Sharma and Holscher for our Q&A session.
So Dr. Albin, thank you so much for that presentation. I can guarantee that I've been motivated by it. So I really look forward to hearing the discussion for this. And so I just wanted to let everyone know, please don't raise your hands, but put your questions, hit the question button and write out your question. And we'll get to as many of them as we can. And then keep those reactions coming. We love to see those reactions.
That's been fun. I think community health workers got the biggest energy so far.
Not surprised.
Yeah, they're very reinforcing. So thanks a bunch. So we'll start with a few questions. So these are two questions that are similar and they kind of have several parts, Dr. Albin. So I'll kind of start and kind of summarize both. But people were wondering about who provides nutrition education. And then there's several questions related to that nutrition education. So why don't you talk about that? Because then they're asking about the focus of those what's the content of those?
So we're talking about in what setting? Patient setting or all settings? I could touch briefly on all settings. Yeah.
Maybe touch on all settings because it didn't specify.
Well, so in a culinary medicine context, you need 3 levels of expertise. You need clinical or medical expertise about the role that food plays in managing and treating health conditions that you have to monitor in the context of other treatments. You need nutrition expertise, as would traditionally be dietitians, and then you need culinary expertise. And sometimes that's 2 people, sometimes that's 3 people, sometimes that's 1 person. I think we have to recognize that this is a team-based approach. When we look at nutrition education in medical settings, we're not training doctors to become dietitians. We are training them to be the champions for nutrition that is so essential in shifting health system narratives, health system resources, research dollars. Physician voices around this are vital because we need to move them to a place of doing no harm, because a lot of physicians say things that are harmful or hurtful, and they're unintentionally, to their patients because they don't have that foundation. So when we teach physicians, what we have heard repeatedly is that our students love exposure to dietitians, but they want physicians contextualizing nutrition for them. They want to hear, how do I do this as a doctor? So I think the ideal team is a physician-dietitian partnership in medical education, and that is what we have embodied, where we teach nutrition through a collaboration model, and it really builds an increase in physician understanding about how to collaborate and have team-based care. And we take the same approach with our PAs and some of our other health professional learners. The more diverse our interprofessional teams who deliver education, the better, because then we can see each role. But it does take physician leadership to get these things accomplished in medical schools and in residency training and to contextualize it. And then I'll just have one last thing to say about medical education. I have a lot of nutrition and culinary expertise that I've built over the years, but when I do culinary medicine for our GI fellows, I am no longer the clinical expert because I'm not a GI physician. So I actually bring in the fellows and their faculty, and I say, let's talk about the health conditions that your patients and your fellows want to learn about. And my dietitian and I will bring in the practical aspects of how do you make those conversations about food? How do you give patients hope and recipes instead of giving them a list of things they can no longer eat, which is often what we see. And so it's really about everyone's expertise coming to the table and building bridges across the puzzle. And I think we have to be careful not to get territorial there because a lot of us have intersectional skills. And so then when we take it to patient care, in a patient care setting, I do believe kind of that culinary medicine should have a little bit of purism in the sense that if we're practicing medicine, we need health professional engagement leading it. If I am looking at a culinary medicine intervention in a health system, it needs dietitian and physician engagement. It needs to have health outcomes tracked. And we need to be able to do the same thing that we would do if I prescribed you a blood pressure pill and never looked at it again, I would be practicing bad medicine. If I prescribe food and I don't understand the health impact and I'm not managing how does this affect your other diabetes medications now that you're receiving food, that has to be a team-based approach again. However, there are not enough people doing food as medicine. There isn't enough opportunity for people who are not accessing the health system to get into the spaces and places where these things are done and taught. So I think community culinary nutrition is a huge opportunity for us to navigate people to these resources. So when we think about using our community health worker teams in the community setting, we are having both dietitian and social work leadership over what the model looks like. So we're actually in the middle of designing a newer model where our community health workers are trained by our dietitians and social workers to feel really confident about what their role in community nutrition education and awareness is. What I believe anyone can do is learn about evidence-based nutrition education resources that are everywhere. We have to point them out though, because there's a lot of noise. And so I think community health workers can be a key lever in navigating people to the right tools and resources where they can learn more and build context. Navigating them to registered dietitians when they have complex nutrition questions, because I think that is something that's very personal. And when we take a public health approach, almost all of us can be ambassadors for evidence-based nutrition resources, but we need to have the right people getting into the weeds with our patients, and they do have to have the clinical nutrition background. And then thinking about what this looks like on social media, again, amplifying the voices of evidence-based resources. We don't all have to have all the answers. We can lead in with those that we're partnering with. But there's so much work to be done. We need everybody with boots on the ground and finding a place and space to make an impact, and then trying to keep it centered on the vast array of science that tells us what and how we can be doing better. And we're not trying to achieve perfection. We're trying to achieve better.
I really like your how you distinguish between public health nutrition and when you have like a medical issue. Because I think a lot of people, when they see public health guidance, nutrition guidance, they say, oh, that doesn't apply to me. Well, everybody has individual nuances that you really need to see someone one-on-one to take care of. So I think that there's a disconnect there sometimes with the public.
Well, and people want things to feel personal. So I always say, you might have diabetes, and we're talking about a public health nutrition concept. It applies to you and your whole family. You know, they might not have diabetes, but the concepts of we are so far off the mark that we all need to move towards basic public health guidance before we get obsessed with personalizing it to specific disease states. But we do have to monitor people with specific disease states so that we don't do harm by not adjusting their other medications. That's actually the most fun I have in medicine these days, is de-prescribing when I see culinary and nutrition interventions changing people's health trajectory, and we have to take them off medicine.
Great. I love that too. Dr. Sharma, do you want to ask some questions?
I think I have a question that probably is on many people's minds. I see a question in here too. And how did you get the service to be reimbursable? What did that look like? Because it's definitely not a fast road to reimbursement.
And it is so complicated. And I will tell you, I probably had 300 meetings to get that off the ground with health system leaders, because when you do things that don't fit the box, people need you to tell them what you're trying to do multiple times before it makes sense. And it's not because our leaders don't care, it's because they have a lot of tabs open, right? Their bandwidth is small, and we have to simplify what we're asking of them. And so that's why I started really small, because I thought, you know what? Cardiologists and hematologists do e-consults all the time. They're very helpful to me. So I could be a resource in partnership with a dietitian, creating access where these patients previously couldn't get advice. So I'll just give an example of a simple question that we would maybe get. So patient is coming in and they are a vegan and they are struggling with getting enough calcium in their diet, and they want some guidance on culinary strategies for getting calcium in their diet without dairy products. Or maybe we have someone who's struggling with food insecurity and they also have high blood pressure and they want strategies for eating the DASH diet that their dietitian might have told them about, but they don't know where to go in the community. So sometimes it's bridging the social and nutrition and culinary and medical aspects of things through simple advice that no one else has time to put together. And so e-consults are a Center for Medicare and Medicaid Service benefit. And we simply had to get it in our EMR that we had a culinary medicine version of that. And the first ones we did, we had no idea if they would get reimbursed, but we billed them and they got reimbursed. And we have published a couple of papers of that on that as well. So if you just search for culinary medicine e-consults, they're all open access. And that built the brand in my health system that culinary medicine was a clinical intervention. And I started to tell people, oh, you see in the chart, the notes that our team provided for this situation. We need to take this to the next level. The next level was basically convincing people that many of our patients who don't have access to a dietitian due to lack of payer reimbursement, for example, if you have high blood pressure or you have high cholesterol or you have a GI condition, many times people can't get health system reimbursement for seeing a dietitian. And so it's almost like we're going to wait till your kidneys are dead and now we're going to let you go. And so it's honestly true, right? CKD can see a dietitian, but before that, we're not intervening when people are asking for that help. And so we took a model of physician billing. So I am a primary care physician. I embedded everything within the primary care context, and I see patients first, and I help endorse the importance of food and nutrition. I spend a lot of time digging out their stories with food. And if we give people food advice without knowing their stories, we can also do harm. So we understand their food trauma, disordered eating, food insecurity that they've faced, how they've been approaching change. And many patients need to tell me everything that has harmed them in the healthcare system and all the gaps. And that is almost therapeutic for them to be able to move forward. And we also process a lot of psychological things. And people will share about how they use food to treat something that hasn't been treated in any other way. And so it opens a lot of doors for me to bring in my psychology and psychiatry colleagues as well as others. And then after I've done the work of getting someone's trust and helping them see the connection of food and nutrition to their health problems, and that it's a tool in the toolkit, not meant to replace everything else they're doing, but meant to add, I then pass them to my dietitian partner who is ready to bring them practical strategies and help them set goals. So there are two benefits to the strategy that we take. I bill on time, so I'm able to bill at a higher level for the time I spend with the patient and the time that I discuss and debrief our approach with my collaborator, because that's one of the newer changes to billing is that we can bill on all the time we spend even documenting on the same day of care. And that allows me to cover my time and my dietitian's time. And she is not billing, but she's going to document what she's discussing with her patients, but it's a patient-led interaction. And she personally has shared that she feels less rigid than following traditional MNT guidelines because she can talk about whatever that patient wants to talk about. And it might take 30 minutes to land on one small change or one small recipe that they're going to try, but she's able to really meet them where they're at and then direct the whole conversation to what they want to talk about. And then finally, shared medical appointments are not a new concept. They're used in pediatrics for well child care. They're used in OBGYN for prenatal care. We simply brought them to community kitchens. And there's two things it takes to bill healthcare. You have to have a lease. I wrote the lease, and then I went to the real estate office and said, hey, can you fix this? This is my idea. I used some AI to help me. What do we need to do to say this church kitchen? We have 2 churches and a food pantry that we have agreements with. And this space is UT Southwestern Culinary Medicine for 5 hours on Tuesday afternoons. And the second piece is we have to pay a CMS, Center for Medicare and Medicaid rate to lease the space to be able to bill for health services. That's it. Those are 2 small things. And so if we pay them the rate, which helps support our community partners, and we have a lease agreement about what clinical care looks like there, then now I have a kitchen. And that overcame the barrier of not having a kitchen in our health system. It also means free parking and no traffic and easy to access and at a familiar site that people already trust. And so we've had really high engagement and sustained retention in our classes, in part because the churches are trusted names. And the food pantry is a trusted name. And so I bill primary care evaluation and management codes for those to whom that makes sense. Typically, it's a 99213, and we take care of 12 to 16 patients in every visit. And my dietitian leads the entire culinary nutrition program while I meet with individual patients throughout the course. I don't have to see them one-on-one at every visit. You simply have to have individualized information about each of them by collecting vital signs and knowing about their health history and documenting how what you're doing in class addresses those medical problems. And so we've written about this in our Catalyst paper, and we also have a deeper dive on community co-led shared medical appointments that will hopefully get published in the next 6 months or so.
I think that's so interesting because we had a paper where we were trying to get people into the health science center, and it just didn't work at all. They didn't want to come. But then we had a community site and they all came to the community site, and we got a lot of pushback on that manuscript because people said, why are you saying it's not working in the health science center? And what we were trying to say is, no, you need to have it where people are.
Yeah.
So
because it's more convenient for me when it's in the ivory tower, but it's not more convenient for the people who are overcoming so many barriers to show up. And it's just so powerful to see them light up. And some of them will even say, oh, that's my church. I'll come to that. And there's this new connection built simply because they trust the building. They trust the space, and it feels safe.
Yeah. Great comment. Dr. Sharma, another question?
Sure. Yeah, there's a couple of questions on this, which I'll truncate in one. And essentially, just how do you think about cultural adaptation, tailoring, to your patient population? How do you keep them engaged, motivated, and accountable? And so can you speak a little bit to that relational aspect in the community and with your patients that you've built?
Yeah, absolutely. So I think it's important we call it out right at the beginning that my dietitian and I are both white women, and we are here to learn from them about their food. We're here to teach them strategy for food. And the way in which we approach it is we teach recipes as a template. And we say, this is not a guideline that you have to follow step by step. You might look at this and say, I would choose a different legume. I would choose a different spice profile. I would choose a different vegetable. And frankly, it's impossible to create a class that appeals to a wide variety of people, that every single person is going to love every recipe, and we shouldn't try. Right? We should try to teach people that there isn't one right way to eat, that their cultural way of eating is absolutely healthful, and that they can lean into their favorites by applying the concepts that apply to everyone, right? So In our classes, we have a wide variety of ethnic and age and gender backgrounds. And so people share their own ideas. And sometimes they argue about spices. I mean, one time we had to break it up, but most of the time they figure it out because they have different things that speak to the soul. And so I think it's about teaching lots of different recipes, making them very simple, very focused on adaptability, recognizing that people's cultural preferences also might not even be allowed to be implemented in their life if they're relying on food pantry resources, because they might not get what they are familiar with. We've seen that as a huge gap in the refugee population, where sometimes they're literally afraid of eating foods that they've never seen before. And so we also have to acknowledge that someone might want to buy certain foods, and true food equity would be having access to culturally relevant food immediately available and easy to prepare. But that is not our reality. So we're teaching people workarounds, and we're teaching them a way to celebrate their own cultural traditions through adaptability and flexibility, and also being open to try new things that they don't have to like. And it's okay not to like something that the person next to you likes. And I think keeping that open mind is really key. I think of it as the same way that we want to train children to broaden their palate, that constantly exposing us to something new in a low risk setting where we make 6 to 8 recipes in every class, and people will choose which ones they want to try. And that element of choice and exposure, when everyone around you is also doing the same thing, it empowers people to say, okay, well, I'll try that. And most of the time they're surprised. And they go home and they make that new thing in their own way, and they come back and tell us about it the next week.
Well,
and the last thing I'm going to add one other thing back to students, because I love students so much. Dietetic and medical students are the volunteer base that power our classes, and they bring immense cultural and culinary diversity, and we have them share about their food stories and memories with the class, and they also help guide the conversations. And so we bring a lot of diverse voices by empowering our learners to co-lead courses with us.
I love all of that. I think we're at the end of our time, right, Deanna?
Yes, so we're right at the end of time. So we do have a couple of reminders for everyone. First of all, thanks for attending today's webinar. I think it's been fascinating and very motivating, and so we hope to see a lot of these shared medical visits. It's really been nice to learn from Dr. Albin. So if you requested continuing education credits upon registration, you'll receive information in the mail about how to claim those. For those of you with nursing CEUs, you can see the QR code right there. So we're going to pause on it for just a second. So there's a survey questionnaire that you have to fill out for those nursing credits. So make sure you log in and get that. If you have any questions, please email us afterwards about accessing that. You need to download your certificate before exiting that evaluation. So just make sure you follow all of those. Then for the next slide, you can please scan that QR code. We have an event survey, so we always like to hear from you. So other speakers that you would like to hear, let us know, give us suggestions, let us know what you thought of today's event. We'd like to look at those and make changes through the next time. So the slides and the recording will be available. And so those of you who have signed up for this will receive an email with the slides and the recording. And feel free to share them. They will also be on our website at msdcenter.org. So you can look under the Phil Nader Legacy of Health Lectureship to find those. So thank you all again for joining us today. This has been a great event, and I really like how we are focusing on food and medicine and how we can bring them closer together, because we know that they really need to work together to get the healthiest population that we can get. So we're committed to that, and we hope to help you achieve that as well. So one more time, I'd like to thank Dr. Albin. We're really fortunate to have her in the state as a resource, and we hope to see you at our next webinar. Take care, everyone. Bye-bye.